therapies. This is more, I guess, medical. At the same time, to me, um, there's nothing. The best medicine I know is staying active. So um, everybody knows who's here on the panel: Dr. Kramer, Dr. DeVay, and Dr. Paul, and Wayne Gillespie and Tony. And so we're going to start with Wayne, and you can ask your questions. And if you have questions, just hold up your hand or pass it.
Okay.
Look directly into it.
Okay. I got it. How is the MS search and MS going? And the new drugs and the new breakthroughs.
Let's hand that to our researcher.
You don't want to say it? No, go for it.
Yeah, so yeah, this is a fun area. We've had one trial for a new type of drug called tyrosine kinase inhibitors, which unfortunately did not work out. There's a second one in that same class. We're going to see the data in another couple of weeks, which shows you that clinical trials are experiments, right? It's not like the iPhone 16 sneak preview, early access to Gene. I don't know if you guys probably, yeah, most of you guys probably remember how Gmail was like invite only, and like it's not like that. A clinical trials experiment, sometimes it doesn't work out. But there's a whole new, we classify drugs into classes. So there's a whole new class of drugs that works a whole new different way. We're gearing up to start that trial, and I think we should begin recruiting in the next month or so, next week to a month. We've got like one signature left to go after a year of lots of back and forth and negotiations. But yeah, there's additional clinical trials. There have been a lot of studies on stem cells. There's been a lot of therapies that are super effective, including therapies in the past that are maybe super effective, but also super toxic, that it winds up being, on average, a not so good deal if you just want to look at it from a overall perspective of just sales of a drug, right? I guess that's kind of a vote, right? But people stopped writing it because we have stuff that maybe is pretty effective, maybe not quite as effective, but much safer, right? So I think it's a great time to be doing MS, right?
I agree. Every time we come up with something new, we learn more and more about how the disease works and the components of the immune system that are failing in different people, and we're learning more ways to treat the disease. As of right now, our treatments really are still preventing relapses, decreasing new lesions, and decreasing the rate at which the MS brain shrinks. We have not yet really figured out how to slow down the progression that some people experience. We haven't quite figured that out, but I feel like some of the new research that's come out in the last even year, we're getting closer to understanding what parts of the immune system are involved, how to save those nerves, and definitely we're getting closer.
Yeah.
Dr. DeVay, the drug that you were talking about, what classification does it fall under? Is this the one that failed and the one that's going to study? Is this a DMT, or is this something to treat some of the symptoms?
Yeah, so, all right, so hold on. The drug I just talked about is FDA approved. It's out there. A doctor can just write it, prescribe it. Of course, you find the infusion center. It's done. It's FDA approved. It's out there. The stuff that I was just talking about a second ago that I mentioned, these are DMTs, disease modifying therapies. But that's actually a good question. I don't want to put you on the spot, but I don't think that we pay enough attention to the research that goes on both for symptomatic treatments but also in rehab. I don't know if there's anything to I actually don't know if there's anything to say, so maybe we'll all learn something.
Sorry.
Yeah, no, we at rehab are also kind of on the same level. We're still trying to understand how to best approach this complex problem, which we look at it from a functional standpoint, like at the level of activities of daily living that we all engage in. We're still at a point where we're trying to classify MS generally. We have been doing that, but now I think there's more research where we are at a better stage where we can classify the condition functionally a little better. And so we can categorize interventions also according to it. And generally speaking, there are now, with all the micro level categorization, if you want to talk about it broadly, there still at the functional level, there are like 3 levels, 3 categories of severity, mild, moderate, and severe. And there are scores for it. There are tests and measures for it. But so that's the first thing. That's what we are at. We're still coming up with better protocols for exercises, therapy, modalities, and all. But we just like medicines, we're still figuring this out, and I think we're getting better. I can take the liberty of saying that, but we need a multidisciplinary approach to try to attack this condition. I guess that's the best I can say at this time.
All right, y'all ready for this? The question that I have. Okay, it's what meds for controlling body temperature due to lesions? What type of meds are there for controlling body temperature due to lesions in on hypothalamus, thymosis, whatever?
To my knowledge, there are none. I think we're good now. Yeah, it came back on. Yeah, to my knowledge, there are none. Once the hypothalamus is damaged, we don't have a synthetic way to make the hypothalamus function properly, is my understanding.
Dr. Paul, this is what can we do as patients to get the therapists more involved in our care? Or uninvolved in our care, I guess it is. Sorry.
More uninvolved?
Yeah.
More uninvolved.
More
It
involved.
says uninvolved, but I
So
think sure.
can somebody define what,
Yeah.
like, what are you looking for there? Because to get a therapist uninvolved in your care, you just don't go to therapy. So
Well, I mean,
understand the
it
question.
said uninvolved, but I think it meant
The
involved.
question is, up until recently, there's not been therapy for MS. It went along with something else, and that is in the process of changing. What can we as patients do to help that happen?
Oh, to improve like their involvement and their education. Okay.
Yes.
Gotcha.
I think there are many angles to this question. One is, of course, access to patients, and this kind of works on both sides: access of patients to therapists and access by therapists to the patients. So that's an access problem. Maybe another angle is the insurance, and that also needs to change. Insurance kind of lags 10, 15 years behind whatever new protocol comes. Besides those, apart from those, I can tell you there's better therapy protocols. Now we have a better understanding, and we can, time allowing, we can go to the details of it, but we have better understanding of how to approach people at different levels of functional limitations that I was talking about a minute ago. Access, and then besides that, there is home therapy programs also that can help people who have this to remain engaged when they're not working one-on-one with their therapist. But I guess what the question means about with access is more about physical access, which I guess is beyond the scope of what I guess. Yeah, maybe you can.
Yeah, I think on the physician side, I think I have a little bit of a different perspective, because you only see the patients that come to you. What you don't see are the patients that are given a, and I see this happen a lot in Northern Virginia and the DC area. Oh yeah, you're having problems. Here's your script for a physical therapy. Here, go, have fun. And maybe you're seeing it in an institution that's Central, Georgetown, Hopkins. It was the same way when I was in Miami too, right? Oh, but you live an hour away or 2 hour. It might be only like 20 miles, but it's 2 hours in traffic, right? So find a physical therapist that's close to you, and this is why I come back to the idea that as patients, I'm hoping that we empower you guys to ask for a physical therapist that at least specializes in neurology. I think we were just talking about how we can get some of these neurology specialized physical therapy. There are certifications in MS, but at the very least, specializes in neurology. I, for one, and I think I can tell you, I'm probably the only person, at least in my region. I don't know what Dr. Kramer does, but I will actually write on the referral must be neurologic physical therapy, and I will not refer patients to facilities that don't offer that. But I'll tell you, 9 out of 10 neurologists or even MS specialists don't do that, in large part because we as physicians don't necessarily see, unless you really, really pay attention to that, don't see what happens at the other end of the tail, right? We rip off a script, we give it to you, or we do the same thing online, whatnot, right? So if that feedback loop isn't there, so we need to empower you guys to ask for what you need. I really think that's the way to move the needle, to be honest, unless Dr. Kramer has different ideas and her practice milieu is very different than mine, right? I'm in a super urban area.
Yeah, so our resources, of course, are spread out a whole lot more. I mean, we're not driving 2 hours and covering 2 miles. I mean, we're pretty far apart. So I know who's good at Parkinson's. I know who's good with migraines and craniosacral. I know who does MS. And some of it is just talking with my patients about who's been good. I wanted to give you a little bit of a tip to answer the question directly. How do we get, basically, you're asking, how do we recruit people into our team? How do we get people more interested in working with MS? And I'll tell you how I got interested, and maybe this will give you some ideas. When I was a baby neurologist, I hadn't done a fellowship in MS. I was in general neurology, and the MS patients that I saw were willing to teach me what it was like to live with MS. They invited me into their world. They explained their symptoms. And the more I got to know them and understand them, the more I thought, we got to do something here. And the more I went out and found education. So if you've got a young physical therapist, occupational therapist, speech therapist that you're working with, let me tell you, when we're all younger, we're much more enthusiastic, right? By the time you're in your 50s, you're just kind of like, I really don't think I can learn anything else new. It's not true. You can, but you're going to get more buy-in with somebody who's young and enthusiastic and has the energy, and just talk to them what it's like having MS. Just invite them into your world. You're not going to give them the basic science insight. You're not going to give them their textbook knowledge. They're going to go and find that when they're working with people that they really want to help. And you guys do this in spades. Like, you are all so amazing to work with. But just telling people what it's like. You know, I work out today. I do 20 minutes of exercise. I'm worthless for the next 2 days. It's kind of like, I love Dr. DeVay's example from earlier, somebody training for a marathon. You cannot run a marathon every single day and expect to function. You have to do it in pieces. But living in an MS body is like running a marathon every single day. And so understanding for a person who doesn't have MS, that's hard to grasp until that's been explained to them. So reaching out to those therapists may be a way to kind of recruit people into the team, get them interested, and getting more education and more experience out there.
Thanks to both of you for giving it a good direction. I just to add a few things quickly. Just like there are specialty areas in medicine, there are specialty areas that are now pretty established in the field of physical therapy. The concept of just being a general physical therapist is kind of fading out now. So you have neurologic physical therapists, and there are advanced certifications for that. There's orthopedic physical therapists. There are cardiac physical therapists, and then there's residencies also coming in. Becoming more and more popular. So conferences like this, retreats like this, spread that awareness. And the more you know, the more you can seek the right kind of person to get the right help. And of course, neurophysical therapists would be the most capable people to treat conditions like MS. But having said that, you might still have secondary orthopedic conditions arising out of it. Then you will know you probably should have a consult with an orthopedic physical therapist.
All right, y'all's next question. Is there any surefire way to know you are having a flare-up or relapse or whatever term you decide to use?
There's one way.
There's one way. If your symptoms match a new enhancing lesion, we nailed it. We got it. No question asked. But how often does that happen? Not very. Yeah, I don't even know the percentage of the time. And sometimes we don't even get an MRI at the time of a flare because the treatment is going to be the same. So if one of my patients is still struggling to pay for their last MRI, I'm not going to pull out the surefire way to prove this is a relapse at another couple $1,000 expense to my patient when I can give them $5 worth of prednisone and do the same treatment we would have done anyway. In some ways, it's not important to know for sure what's a flare. And let me define flare. A flare is a new inflammatory attack on the nervous system. Well, we happen to know that inflammatory attacks are happening on the nervous system 24 hours a day, 7 days a week, 52 weeks out of the year. So if you're having an increase in symptoms, are you having an increase in symptoms because of inflammation or because you've overdone it or because you have a urinary infection? Go for the thing that changes your treatment. So if a patient of mine calls and says, oh my gosh, all of my symptoms are worse, I think I'm having a flare, I often won't start with prednisone because it could be an infection. And if I give you an infection, the prednisone is going to make that infection a whole lot worse. I one time just sat down for giggles, I was giving a talk to a group of physicians and I wrote down a list of things that had been sent to me or that physicians or patients had thought was MS that was not MS. And urinary tract infection, sinus infection, GI bleed, torn rotator cuff, throat cancer, lung cancer, overdid it at the pool the day before and it was too hot. I mean, just all kinds of crazy things will bring out old MS symptoms. It's when you're having a new neurological symptom that we become more suspicious that there's new inflammation. And that's important because the disease modifying therapies that we use are supposed to stop that new focal attack. And so we want to know, is your medication working? And that's why that new flare can be so important. But Dr. Kramer, sometimes prednisone helps. That means it's a flare, right? Nope. Sometimes prednisone works because it's a little hot rocket, and sometimes it shoots you right to where you want to be and gives you the energy to push through, and sometimes it burns you on the backside. So prednisone is kind of non-specific. If it doesn't work, doesn't mean it wasn't a flare. And if it does work, that doesn't mean it is a flare. Well, then why do we use it all the time? Because we really want to help you feel better. And the prednisone helps you get better faster if it's inflammation. And sometimes it works even if you're not having new inflammation. It gets complicated, doesn't it? So the only surefire way to know is you have a new symptom and it matches a new lesion that is enhancing on the MRI. But practically speaking, we're not always going around and looking for that surefire answer.
Yeah, I agree. I'll tell you the way I look at it and what I tell patients, which is maybe a little bit avant-garde, but I encourage patients to separate the symptoms from how the MS is doing. Okay, because you can have new inflammation that's maybe in a part of the brain that's not so symptomatic, but that's actually very relevant to me because that means that we could be doing a better job of controlling your disease, and maybe you need a stronger disease modifying therapy. Okay. Now, even if somebody comes to me with an enhancing lesion, but they don't feel all that bad and or maybe they don't feel anything, right? That doesn't mean that I need to give them steroids and admit them to the hospital and do a big song and dance because they're feeling good. Now, the flip side, let's say that we have a 110-degree heat wave and you're feeling bad and you can't get out of the house and you're like stumbling on the way to the kitchen, okay? And let's say because this happens every time there's 110 degree, even though we don't get 110 degrees here, but you used to live in Georgia and this is what happens when you get 110-degree heat waves. That doesn't change the fact that you're stumbling on your way to get to the kitchen and there's no way you're going to make it to your car to get to work. And somebody's got to do something about that. Somebody has to. If I don't do it, then you're left there unhelped, right? So I think it's useful to think about these as different buckets, rather than really trying to psych yourself out which is which. And then the other part of it is with experience. Sometimes, like people like Dr. Kramer, myself, Dr. Moore, all these names that you've heard and know and love, when you start seeing something a lot, you can get pretty good. You can get good at guessing and figuring out the best way to help people out. And that's the way everything in medicine goes.
Educated guesses. That's what we call them.
Okay, the next question is Bell palsy or vertigo a part of MS? And does everyone that has MS ever had Bell palsy or vertigo or both?
Most commonly Bell's palsy, which is complete loss of movement on one side of the face. Most of the time that is not caused by MS. Most of the time it is caused by the varicella or the chickenpox shingles virus gets into the facial nerve and causes weakness. Now, can it be due to MS? Yes, because in the brain there is a place that if a new lesion occurs, it will knock out that nerve as well. Vertigo is very common. I've had vertigo. I don't have MS. Vertigo happens all the time. So if somebody with MS develops vertigo, one possibility that I consider is that it could be the MS, but you could also have a crystal loose in your ear. My dad has that. I like to tell him his rocks are loose. And he goes to therapy. They put the crystal back in the ear. Like Dr. Paul was saying earlier, if there's a peripheral problem, if it's in the ear and not in the brain, there are very effective therapies for recalibrating. And if it's a crystal problem, you just dump the crystal into the trash bucket and it dissolves into the ear and quits bothering you. So Bell's palsy and vertigo would be examples of two symptoms that if one of my MS patients called and said, I'm having this, I think it's my MS, I might say, hang on, let's see if it's something else because the treatment's really different. Now, for Bell's palsy, you use prednisone either way. But for vertigo, you would use vestibular therapy. You might have other things that you would do if it's the inner ear. So those would be examples of two symptoms that I would not assume are due to the MS, and I would try to make sure that it's not something else first. And then the last piece of that question was how many people with MS have had Bell's palsy or vertigo? I don't know the number, but it's probably not a whole lot more than everybody else who doesn't have MS. They're just not typical MS symptoms, even though they can certainly happen in MS, is the way I would think about it.
Yeah, the only thing, and I was talking to somebody about this earlier, in a strict sense, Bell's palsy, by definition, is an infection of that nerve that makes your face twisted. In reality, especially in some of these busy ERs, I know it's happened in our ER, I know I see this all the time. Someone walks in, the ER docs they pretty much do medicine by kind of walking room to room. Oh, you're not dying. Oh, you got a twisted face, you got Bell's palsy. And you can get facial weakness that's not Bell's palsy due to MS. And that's so sometimes these symptoms can be similar to things that are MS symptoms. The other thing I want to get at the spirit of the question, and I got a good quote from my neighbor, Heidi Creighton. I know you know her. I don't know Suzanne. I don't know. So they've met her. Yeah. So Heidi always says, if you've seen someone with MS, you've seen one person with MS, right? You guys all know this. Everybody's MS is different. So I just wanted, I felt like there was sort of I wanted to address that an undercurrent that I felt in that question.
Yeah, I agree, and I'd just like to add a few things to the vertigo question. Yeah, technically, if it is a new lesion somewhere in the vestibular areas of the brain, including places like cerebellum, it could be that might be causing the dizziness or vertigo. But I have read, and I don't know if you guys would agree, that some MS patients, for some unknown reason, also have vertigo because of crystals. And I don't know, I've tried to look for reasons for why people with MS actually have a little bit more of the crystal-related vertigo. But if there is vertigo, and then it's an important a part of the assessment should be to know if it is due to a central cause or a peripheral crystal-related cause. There is a third potential cause that might also cause dizziness, but and not vertigo, is if it is a cardiac-related problem, which can also sometimes happen if brain centers that control cardiac nerves get also affected. So people, I've heard people coming and saying, I'm MS patients saying, I'm dizzy. I like to actually have them describe the word dizziness a little more. Dizziness could mean fainting. Dizziness could mean my head is spinning or the room is spinning. And those subjective terms actually are very helpful to us in making our initial kind of differential diagnosis.
Then when you start talking about dizziness, you can get ooh. That's right. Forget this. Yeah, when you start talking about dizziness, it's a lot of things. I think especially in the Indian accent, dizziness sometimes refers to confusion or brain fog. I've seen people who feel unstable because they don't have good sensation or they have a little bit of leg weakness, and that can also feel like dizziness. And sometimes the word vertigo gets in there. So, I think, be very, very careful. And this is not on you guys. It really shouldn't be. It really should be on our trainees to be very careful of the words that are being used that come to you as a physician or a clinician, and make sure that you mean the same thing that your patient does.
Yeah, my poor students, if they come and tell me that the patient they've gone to see is dizzy, I'm like, oh, okay, so they're passing out and they've seen the cardiologist? What? Yeah, it can mean you're passing out. It can mean you're lightheaded. A lot of dizziness. I've had people with numb feet, and they described it as dizziness.
Yes.
So dizzy means different things to different people, and whoever's talking with the patient needs to understand that dizzy is kind of an umbrella term It can mean a whole bunch of different things. So for example, I've had vertigo. When you lay in a certain position, the whole room spins around until you throw up. I mean, it's terrible. That is true vertigo. But I've also had dizziness. When I was first put on blood pressure medicine, every time I stood up too quickly, the whole room went gray and dark, and I felt like my legs were jelly and I was going to pass out. Different dizziness, very different reasons. And it's important for us to help sort that out.
Yeah.
Okay, backing off of talking prednisone. What do you do for your patients that are allergic, example, anaphylaxis to steroids?
I'm curious to hear what your answer is. We want to try this thing again?
Yeah, that's right. Yeah, so for allergy is one of these other fun words. True medical allergy is a very, very specific thing. So there's true anaphylaxis, but then there's also bad reactions to prednisone. If someone's having a lot of symptoms, you can try to help them with their symptoms, which is actually my sort of go-to. And there's other ways to treat relapses that I feel like we used to do back in the day. For example, IVIG or plasma exchange in the hospital. If someone's bad enough to be in the hospital, those are some options. ACTH was one of these things that we used to do way back when, before they pulled on apparently they pulled a this is like before I started training. They pulled a Martin Shkreli and they turned this cheap thing into something that's like tens of thousands of dollars. And I've been trying to work with the company on that to make it more affordable and more accessible. Long story short, hasn't really gone anywhere, but there's always a million ways to skin the cat.
How do you treat pre-MD, when you go in and have your DMT, no matter how it's administered, how do you treat that patient who may have the steroid allergies, anaphylaxis wise?
Yeah, anaphylaxis. I think that there's a couple of patients, or even for that matter, bad reaction. I had a patient on an infusion therapy, right, and you give a little bit of prednisone beforehand. Well, that prednisone was enough to set off her psychosis. And in fact, when she was first diagnosed with MS and she got the IV steroids, now this is not anaphylaxis, but equally severe, she lost it, started accusing the entire hospital staff of abusing her and everything like that. We got to the point that we were about to discharge her from clinic because we couldn't figure out, we just couldn't handle it, and it wasn't therapeutic. 2 years later, she comes back to me. I put her on infusion therapy, a little bit of prednisone. And I remember it was a raining, storming day. Everybody was trying to get out. The infusion was finishing. My nurse looks away for a quick sec. She rips out the IV and bolts. And that's when it dawned on me that that little bit of prednisone was a steroid psychosis, and that's what happened 3 years ago, right? So for her, then I put her on therapy where I really didn't want to use any sort of steroid in her, so I put her on a therapy, still a highly effective therapy that did not require a pre-medication. So once again, there's the ways we usually do things, and then there's always workarounds. There's always a way around that gets you to the end that you want to be.
And I think if we think of steroids as a symptomatic rather than a disease modifying treatment, that helps the conversation also. So years ago, studies were done where we really didn't have any disease modifying therapies, and pulse dose steroids, where regular solumedrol was being used to try to prevent future damage from MS. This study showed that steroids don't prevent future damage. They help you get better faster than you would without the steroid, But in 6 months, you're going to be in the same shape whether or not you took the steroid. So the steroids are not life-saving, brain-saving treatments. They help you feel better faster. So for some of my patients that don't tolerate steroids and have an immune flare, we simply push through. We use other medications, therapies, rest, time off from work, whatever it takes to get them through the flare, because statistically in 6 months, they're going to be in the same place whether we use the steroids or not. So if they can't use the steroids, let's not argue with that. As far as pre-treating patients, I actually have a small number of patients that I use the infusible therapies, and we don't pre-treat them with steroid. Depends on how itchy you want to be through the whole process. Usually for the first several, I won't do that because you can really react when you're first taking Ocrevus or Briumvi. And so I won't do it for the first few, but if they don't like the way the steroid makes them feel, or they have a reaction to the steroid or whatever it is, I have a small number of patients that just take the medication without the pre-medicine. We might use more Benadryl. Sometimes you can use a different one. So somebody doesn't tolerate Solumedrol. All right, try dexamethasone. Nope, don't like either of those. Okay, sometimes we can get away with prednisone or oral dexamethasone. But like Dr. Deve said, we have a lot of ways of working around it. Steroids are not required therapy, I think is the take-home message that I want to leave you all with.
Okay, MS and itching. There was a story in Momentum about this problem. What do you think about this issue?
What was the first word?
MS and
MS
itching.
and
MS and
itching.
itching.
So itching is probably on the spectrum of neurological increased activity and pain. If itching gets extreme enough, you'll describe it to me as pain. If it's milder, it can be itching. It's a variation. Now, the first thing that I always tell folks when they say, I have MS and I'm itching is, please make sure it's not something else first. Because if it's MS-related itching, we're going to struggle because it's very hard to turn down itchy nerves without turning down all of your nerves. So we want to make sure it's not a dermatologic condition. You didn't change soaps and you're having a reaction to it. Or I've occasionally heard of gallbladder issues presenting as diffuse itching. So if we're busy trying to give you prednisone and gabapentin and amitriptyline to calm down nervous itching and you have a gallbladder problem, we haven't done you any favors. So you first want to make sure this is another one of those symptoms that's not, oh yeah, that's MS. Maybe, maybe not. So that's how I would approach it. There are symptomatic treatments. I just mentioned some of them. Gabapentin can be used to calm the nerves. The amitriptyline can be used to calm nerves. Sometimes we'll use things like trileptal, baclofen. There are a lot of different things that can work, but nothing is specifically for itching and MS. So we're using medicines that help to calm down nerves in general. And of course, when we calm down nerves, we calm down the nerves that keep you awake and help you remember your passwords and how to, where your car is parked. So we want to make sure that we're on the right track when we're treating itching and MS.
Yeah, pretty much. Itching is almost as mushy as dizziness, except worse. I mean, you really, but yeah, nerve. I think where it intersects with neurology is nerve pain can present like itching. It can present as like water running down the legs, cold sensations. The only other thing that I would add to that is the one exception to what you mentioned is there are certain antidepressants which are really, really good for nerve pain that can give you energy. So I use some of those. I tend to use some of those as well.
Y'all's next question. When I was diagnosed, I was told to watch my electrolytes and make sure I don't get dehydrated. I drink over 80 ounces of water every day. How come I'm still getting dehydrated?
How do you know you're dehydrated? How are we defining dehydrated?
I think there were a lot of questions in that.
No,
In
but
the
Kelly, if it's your question.
Like-
Well, no, I'm not trying to call anybody out, but dehydration is a medical diagnosis, right? I mean, it actually has terminology. So if you feel dehydrated, then we're going to have a conversation. Like, let's say you come into my office and ask me this question. I would say, tell me what you mean by dehydrated. What does that feel like? What are your symptoms? Are you dry mouthed? Are you lightheaded when you stand up? Every time the doctor checks your blood work, is that BUN creatinine ratio showing that you're dehydrated? Okay, then we have some medical definition for dehydration, because you really can't and shouldn't be dehydrated drinking 80 ounces of water a day. You just kind of can't unless there's something wrong with your kidneys. Now, a lot of medications will make you feel very dry, but you're actually not dry, and there's no amount of water you can really use to overcome medicines that are drying out your mucous membranes. I have a friend, for example, who has Sjogren's, and Sjogren's is a condition that makes your eyes feel very dry and your mouth feel very dry. And I'm a bad friend, so we kind of joke about this, and I'll be like, look, we could put you in a whole swimming pool. You could drink the whole dang thing and your mouth is still going to be dry. Eat a mint and let's move on with our day. Because it's miserable. It's miserable. She tells me to suck it up when I complain about stuff too. So she's always dry, but she's not dehydrated is kind of the conversation that we have, but it feels like it. Or she may be lightheaded because her medications are dropping her blood pressure. Or you may feel like, you may feel dehydrated when you're really not, I guess is my point, and why my question was, how do you know you're dehydrated as opposed to what are your symptoms?
Yeah, I think a little bit bigger picture, right? Dehydration is one of these things like infection and like heat and like overdoing things is going to make your MS symptoms worse, but it's not going to worsen the disease, which is why we say try to stay well hydrated, because there's no point in feeling worse than you need to be. But this kind of question is really a question for your primary care doctor. And my patients who are doing the best have very involved primary care doctors, because this gets into a lot of things that are not neurology. Let's assume that patient was actually truly dehydrated, and let's say you did the urine osmolality tests and all that, right? That's not something I can figure. I know I can't figure it out, and it's really a primary care thing. It's not a neurology thing.
Yeah, because what he's talking about, your kidneys are having issues. We don't know much about kidneys. And Suzanne says we have 10 minutes left, so wrap it up.
You have a couple questions that are going to be faster, and the one I know for answered it's going to be longer, so ask your fast ones first.
Okay, is MS hereditary?
Yes, partially.
Really?
So data, if you have, okay, I'm going to pick on somebody at random. Okay, I'm going to assign you having MS, and his twin brother that haven't met, the chance that the twin brother has MS is 2%. If I grab somebody that's randomly boating on Smith Mountain Lake right now, the chance that they have MS is 0.5%. Not these boats here. They're bounding in the middle of Smith Mountain Lake. The chance that they have MS is 0.5%. So that's the hereditary component. If you go to autoimmune disease, I suspect that number is larger. And you start going to extended families, it's not unusual that you start seeing some family members.
Yeah, so it'll track with lupus and type 1 diabetes and Sjogren's and ulcerative colitis and other autoimmune diseases.
All right. The next one is, what is the best diet for MS?
What's your favorite?
I usually tell people to eat a well-balanced, reasonable diet. So the Terry Wall has a book out. She claims to cure MS. I do not agree with that, but her diet is actually very reasonable. You want lots of fruits and vegetables. The American Heart Association diet is a good one. I usually talk about the Mediterranean DASH diet. The American diet is just absolute not good for us.
Yeah, so there's this is like one of my favorite topics. This goes back to the 50s. Roy Swink, the Swink diet. This is what I tell people: eat healthy. We all know what healthy is. I like Terry Wall's diet, although if you follow it to a T, I don't know about you, but I would go nuts. If I wasn't nuts, I'd go nuts trying to follow her diet. But there's some good ideas in there, and they're worth trying, right? So try gluten free. You know what? Does it work for you? Try dairy free. Does it work for you? If it's not game changing for you, some of this stuff is just too difficult to do. So I think there's some good ideas in her book. I don't subscribe to the idea that you have to follow every last bit of it. Her own data, Terry's own data, shows that it makes you feel better, but it doesn't affect the frequency of relapses. That's the data that she had presented at the American MS meeting.
Okay, next question. Can you age out of MS?
Yes, sort of. We know that as people get over the age of, and we could probably debate this all afternoon, what that age is.
But as you get older,
as a person gets older, the immune system becomes less robust. Okay, this is part of the reason that we don't do research projects with people over the age of 55. Is it because we don't like people over the age of 55? No, it's because they have less frequent exacerbations and are less likely to develop new lesions. So it's harder to use a less active population to do an efficient clinical trial. So somewhere after the age of 55, maybe it's over 65, maybe it's over 75, we have a lot of data that shows that the immune system becomes more sluggish, more prone to infection. This is why older people are more likely to get shingles and urinary tract infections than younger people. But there are well-tracked MS data that indicate that the frequency of exacerbations decreases until right around the mid-70s. It drops off suddenly to not zero, it's never zero, but a lot. So if that counts as aging out of MS, then yes, some people can, but when is it for you? Is it 55? Is it 65? Is it 72? Is it 74? It's a little harder to predict when it's going to happen for any one individual, but it is less likely to attack as you get into that age range.
How do you know this if you don't have research?
well, so I was actually about to jump in and say no and start a fist fight. so
Let's go.
So Jill is right? True immunologic inflammatory relapses, exacerbations, decrease with age, and it's probably a gradual thing, to be perfectly honest, right? The flip side is we know that there's brain shrinkage that happens due to MS. Now, there's brain shrinkage that happens due to aging, but the brain shrinkage that happens due to untreated MS is faster. And then here is, I think, the $50 billion question. It's not like $1 million is not what it was. $64 billion question. The therapies that we have classically had, if you go back to the old school injections, the Avonex and the Copaxone and the beta serons, right? We know that they do some for the relapses. They reduce it by about like 30-40%, which ain't bad. But we know that those do nothing for the brain shrinkage. The therapies that we have today, including the Ocrevus's, Briumvi's, Lemtrada's, Tysabri's, we know that they're much more effective at stopping relapses, as we saw with the MRI data, right? Like 90 some percent, 95%, right? How much do they do for the brain shrinkage, and do they do anything for the brain shrinkage? And we're just getting some of that data now. And I really think that, but we have data even from teriflunomide and Aubagio that shows that it starts to have a little bit of an impact on brain shrinkage. And that's actually, and there's a lot of differing approaches. But because of that impact on brain shrinkage, we're nowhere near 90 something percent. In fact, we're probably right now somewhere 20 to 30% good at stopping brain shrinkage without, in someone that doesn't have relapses. That's why I'm doing the trials that I'm doing. But I do think that we're impacting on it some with the therapies that we have. And there's a lot of people who stop MS therapies at a certain age. My practice pattern is the opposite. I almost never stop MS therapies of any age unless someone's really having problems with them, and most people are somewhere in between.
Yeah, and my practice isn't that, okay, you're 72, we're done. I have a tendency to say, you're getting into your early to mid 70s, maybe we ought to decrease the efficacy of the medication because now the risk of infections is going up as you age and the chances of an exacerbation are going down. And we don't know at any given point when any one person is a candidate for stopping disease modifying therapy. Now, I said that you age out, sort of. The other thing that's happening on top of the MS, like Dr. Dave has pointed out, the brain shrinking is faster in somebody who has MS than somebody who doesn't. And that's even if you're not having relapses. It's independent of the relapses.
Yes.
So that's happening. And then there's something else that happens at the same time. We're all getting older. So you add that on top of the MS, you'll never age out of your MS because now you're going to feel that old damage more because you have less youth and vigor and reserve to make up for it. And so do the disease modifying therapies help with that? Probably not would be my argument. But again, I don't have a particular age that, okay, no more disease modifying therapy. It's an ongoing conversation that I have with my patients, and some of them stop medicine and some of them continue. One of my patients stopped medicine at the age of 71 and at 72 had a new lesion. And every time she comes in, she likes to remind me of that because she is not wrong.
I would just like to quickly add, there are some, and I'm going to stay out of fist fights. There are some reports at the level of function, specifically at the level of ability to ambulate, and there are some reports, some low-level studies that talk about even though technically all the various types of MS are generally slowly progressive. If you talk about what is happening at the lesion level, there is quite a good chunk of people who have MS who have kind of stayed stable in their levels of ambulation. About, if I recall the report correctly, it's like 50% of people were still able to maintain their level of ambulation. And that's what matters. Even if there are new lesions coming and if it's not of much consequences to you, if you're still able to maintain your level of function, your ambulation level, that's what matters. And so don't lose hope, is what I would say. And again, everyone is different.
No, thank you. That's, when I mentioned improvement a couple of times, right? Where does the improvement happen? The improvement happens because of all of his hard work. Yeah. He is the one, people ask me, like, how can I by the way, they did remelanation studies, 3 remelanation studies, none of them worked. But how do patients improve? It's not because of what she and I are writing for you, it's because of what he's doing.
All of us.
Okay, we got 3 questions left. Which antidepressant is good for nerve pain? Which antidepressants are good for nerve pain?
So Cymbalta or duloxetine is FDA approved for nerve pain. And it is one of the exceptions that Dr. Dave noted that doesn't decrease other nerve activity. So it doesn't tend to make people sleepy or dull. It actually has a component in the way that it works that is a little bit activating.
What was the second drug? Cymbalta?
Cymbalta and duloxetine is its
Duloxetine
generic.
is the generic name. Cymbalta
Yeah.
is the brand.
It's the same medicine. It's just the brand and generic.
Yeah. And then there's other drugs in that same family. You guys know about the Mark Cuban pharmacy, by the way?
Yep.
Yeah. So you can get even like Prestige, you can get through the Mark Cuban pharmacy, and yeah. Yep.
Yeah, for anybody who hasn't heard of Mark Cuban, the guy that owns the Mavericks, he started a pharmacy. He said, this is baloney. You can make money selling prescriptions without gouging the American people. And he sells generic medications at a markup. His profit margin is 15%. I'll tell you in a second what Albaggio's profit margin is. And then $5 for the pharmacist to fill it and $5 to mail it to you. So it's a very affordable, it's an online pharmacy. You're not going to call and talk to a human. A pharmacist isn't going to be available. It's all done online, which helps to keep the costs low. The Albaggio has become generic, as a lot of you know, teriflunomide. It is sold on Mark Cuban's pharmacy. Varies a little bit, but about $50 for a 3-month supply. And I was able to save one of my patients $2,100 a couple of weeks ago because she had just paid $2,100 for generic teriflunomide as repriced by her insurance company and the pharmacy that her insurance company owns. Don't worry, y'all, I'm writing a book about this nonsense. And she had just paid $2,100. I said, stop payment immediately. I'm going to send a prescription to Mark Cuban Cost Plus Pharmacy. You're going to make an online profile, and saved her $2,050. Isn't that insane? I can't even calculate. I don't even want to calculate that markup.
The exact same story. This poor woman couldn't get any therapy for a year, and one of the nurses found the Mark Cuban, and yeah, that's pretty much she's my patient for life because of Mark.
Yeah, you can get generic Ampera it's very affordable.
I stopped writing it for a while because nobody could get
You
it.
couldn't get it. No, the insurance companies would jack up the price, and the pharmacy would charge you that price because they own
Yeah.
each other.
Sorry, we're answering a question that wasn't.
We're on a soapbox now.
Will MS kill you?
MS isn't going to kill you, it's just going to torture you.
I have rarely seen people die from the effects of the MS itself. That is a very true statement. And especially with disease modifying therapies, we are almost not seeing death from MS anymore.
Even the flip side, if there's a young person newly diagnosed with MS and doing pretty okay and pretty healthy and whatnot, chances are today in 2024 we can probably keep that person pretty good.
I'm having my own little dance party over here because so far y'all answered the questions just the way I like it. All right, your last question, and this is going to fire on a lot of people's nerves.
Uh-oh.
Is marijuana good for MS?
I didn't ask you.
And I didn't ask it.
So this is going to be another, it depends on what you mean by good for MS. It does not treat the underlying MS. We have data that marijuana addresses pain in MS and spasticity in MS and worsens cognitive function and fatigue. It is symptomatic. Think of it as a symptomatic treatment. It's not for MS, just like gabapentin's not for MS, but it can help the nerve pain from MS. Just like baclofen isn't for MS, but it can help the spasticity. Just like Adderall is not for MS, but it can help with cognitive focus and energy. Think of marijuana the same way. Marijuana is variable from person to person. Some people get terrible side effects with it. Some people find that it really helps them in a lot of ways. So is it good or bad? I would say it's neither good nor bad. I don't have a problem with my patients trying it. And I do acknowledge that it has known medical benefits in a symptomatic realm. It's not helping the MS itself. And as long as your symptoms aren't getting worse, there's no data that indicates that it is causing more damage unless perhaps you're smoking it, because smoking things seems to be bad for MS. What are your thoughts?
Yeah, I am really, really concerned. So cognition and MS is also one of my huge interest plates, in part because I work across the street from Jeff Wilkin, who does really done a lot of the cognitive research in MS, and we become really, really good friends just because of the proximity. I am really, really, really concerned about the impact of MS on cognition because it impacts your cognition. By the way, the cognitive decline that happens in MS is unique to MS. It's different than Alzheimer's disease, for example, or just aging. And you can do testing and you can figure that out, right? But it impacts those areas of cognition that are already take a kick from MS. So I actually encourage my patients to stop either smoking it or ingesting it. I think topical CBD is probably okay, and you can get some of the pain relief from it. I have probably not more than 2 or 3 patients using it in any form whatsoever. Maybe not more than 10. But that's, yeah, I think we're still learning more about it, and I would not say that we're out of the woods to say that it's completely safe.
So do you feel that there is or will be data that the use of ingested or smoked marijuana will accelerate the cognitive dysfunction in MS more than temporarily due to the immediate effect of the drug?
That's I think these studies are really, really preliminary, right? But that's my concern. I will say we now moved. The other thing that's different. So I work in a 9-story building. We have all our specialists in one building, including all the rehab people, the MRI. We moved our pain people now into the neurosciences suite. And so we have a very robust, and even before they were on the hospital campus, and our pain group was already a very good friend of mine. So we were already working together, and now we're literally in the same office. And so because of these partnerships, I think, many of my patients are able to feel comfortable because we have so many different specialists, like all in one place, which unless you're really in that kind of setup, it's hard to replicate that. And so that means that I have additional tools that someone doesn't feel like, oh my gosh, marijuana is the only thing that works for my pain. I have very few patients saying that. And I worry also about opiates too, by the way, in terms of, that gets a lot of press, of course, but the same thing. I have very few patients who say, well, the morphine is the only thing that helps my pain and that kind of thing. But yeah, I think we have some resources that I think even no one else even in the DC area has, the way we've kind of set things up and the way we've organized things at Innova.
I tend to think that if I don't have a lot of patients that need a lot of opioids, it's because I don't prescribe opioids and they've gone somewhere else too.
No, but you would know, right?
Not necessarily. I mean, if they go someplace else. So I guess I don't think, and I may be wrong, this research is preliminary, I don't think that adult use of marijuana is going to cause permanent harm. We will find out who is correct when the research progresses.
Yeah, we'll find out.